Okey, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh dan selamat petang kepada semua yang hadir. InsyaAllah petang ni saya akan bentangkan tentang CPG dengue in adults 2015 edition dengan 2020 edition in children lah. Okey. So, dengue is one of the most important arthropod-borne viral diseases in terms of public health problem with high morbidity and mortality. It affects tropical and subtropical regions around the world, predominantly in urban areas. Okay, dengue infection caused by dengue virus, which is mosquito-borne flavivirus transmitted by Aedes aegypti and Aedes albopictus. There are 4 distinct serotypes, dengue 1, 2, 3 and 4. Each episode of infection induces a lifelong immunity to the homologous serotype, but confers only partial and transient protection against other serotypes. Secondary infection is a major risk factor for severe dengue due to antibody-dependent enhancement. Other important contributing factors are viral virulence, host genetic background, T-cell activation, viral load and autoantibodies. The clinical cause of dengue infection. The incubation period for dengue infection is 4 to 7 days, range 3 to 14 days. Dia ada 3 fasa, febrile phase, critical phase and recovery phase, which is reabsorption phase. Okay. So febrile phase, patients develop high-grade fever suddenly and usually lasts 2 to 7 days. It is often accompanied by facial flushing, rash, generalized body ache, vomiting and headache. Some patients may have sore throat, injected pharynx and conjunctival injection. The earliest abnormality in the full blood count is a progressive decrease in total white cell count. So kalau kita ambil FBC, kita boleh nampak white cell count dia dulu yang akan rendah lah, and then followed by platelet reduction. So, critical phase is the often occurs after 3rd day of fever, may occur earlier or around effervescence indicated by a rapid drop in temperature. This coincides with an increase in capillary permeability in some patients. Okay, recovery phase or reabsorption phase. After 24 to 48 hours of critical phase, usually plasma leakage stops, followed by reabsorption of extravascular fluid. Patient's general well-being improves, appetite returns, GI symptoms improve, hemodynamic status stabilizes, and uresis ensures. Okay, so dengue classification. So kat sini kita boleh tengok ada dengue yang without warning sign, ada dengue yang with warning sign, which can lead to severe dengue lah. So probable dengue kan, possible untuk dapat dengue kita boleh suspect dalam patient yang tinggal ataupun pergi travel ataupun ada outbreak area yang tempat dia duduk ataupun tempat yang dia travel lah. And then kalau patient tu datang dengan fever with 2 of the following criteria, memang kita boleh suspect dengue lah. So fever dengan nausea, vomiting kan, loya, muntah, ada rash, ada sakit badan. And then bila kita ambil FBC, kita boleh nampak white cell count dia dah drop daripada normal kan. So itu kita boleh suspect dengue lah. Or any warning sign. So warning sign yang perlu kita tengok dengan teliti lah. Okay, so tanya patient, ada tak rasa sakit perut, ada tak muntah tu sehari berapa kali, more than 3 times. Kalau more than 3 times is warning sign. Diarrhea more than 3 times per day. And then ada mucosal bleeding kan, fluid accumulation. Kalau ada bleeding dekat gigi ke, gosok gigi tiba-tiba, sebelum ni tak pernah kan, gosok gigi ada bleeding, ataupun hidung ada keluar darah ke, ataupun bila period ke, menses ke, dia punya darah tu berlebihan kan. Okay, apa-apa mucosal bleeding lah. And then lethargy, confusion, restlessness. Okay, kalau nampak patient tu sangat macam lembik dah kan, macam confused, itu one of the warning sign lah. Okay, and then bila kita ambil darah tu, kita boleh nampak hematocrit tu increase concurrent with rapid decrease in platelet count. Okay, so severe dengue is bila ada plasma leakage bila ada severe hemorrhage, bila ada severe organ impairment. So plasma leakage tu bila in shock lah, bila patient dah in shock and dah ada fluid accumulation with respiratory distress. So severe bleeding and severe organ involvement ni biasanya boleh nampak daripada darah hati lah, darah liver blood investigation dia. Okay. And then daripada CNS dia pun sebenarnya boleh nampak bila dia dah tak alert kan, bila dia dah confused, itu pun one of the organ impairment lah. Alright. So warning sign apa yang kita nak tengok tadi, ini saya ulang lagi sekali, abdominal pain, yang sakit, patient datang dengan sakit perut, muntah banyak kali, lebih 3 kali sehari dah, cirit lebih 3 kali sehari kan, lepas tu perut dia macam besar dah kan, bila precardial effusion kan, nak nafas pun susah, nampak pleural atau pericardial effusion, both lah ataupun one of it. And then ada spontaneous bleeding tendency, and then lethargy, restlessness, confusion kan. And then kalau hematocrit tu ada tender liver kan, tender liver kita check liver dia, dia sakit kan. And then raised hematocrit, okay, dia ada kategori lah, sama ada lelaki tu less than 6, seorang lelaki less than 60 years 60, hematocrit above 46 is a warning sign. Kalau male more than 60 years, dia 42% above. Kalau female 40% above lah. Okay, so pathophysiology of plasma leakage. Okay, acute increase in vascular permeability can lead to leakage of plasma into extravascular compartment and cause hemoconcentration and hypovolemia or shock. So waktu ni kita boleh nampak daripada clinical manifestation of vasoconstriction lah. So kita boleh nampak tangan dia sejuk, kita boleh nampak dia pucat dah, CRT kita pegang dia, tangan CRT dia more than 2 seconds. And then bila kita ambil BP, okay, bila kita ambil BP kalau CVS ambil BP dia dah raise diastolic kan, raise diastolic, narrow pulse pressure, reduce urinary output. Kalau GIT dia persistent vomiting, diarrhea, abdominal pain, and then nampak lethargy, restlessness, reduce conscious level, and respiratory rate dia macam dah tachypneic lah sebab dah susah nafas kan. Okay, so ini adalah 3 yang sama juga kita cakap tadi. So ada 3 ni patient yang normal circulation dia, and then patient yang compensated shock dengan patient yang decompensated shock ataupun hypotensive shock. So kalau dalam normal circulation, patient tu memang alert macam biasa, CRT dia less than 2 seconds, tangan dia panas macam biasa, pink, and then volume dia good volume kan, good volume pulse, and then normal heart rate, normal blood pressure. Kita ambil vitals semua, basically vitals is normal. So kita tengok patient tu alert, pegang tangan dia, CRT dia okay, warm, and then vitals okay, kencing pun okay, insyaAllah tu boleh discharge lah kan, maksudnya discharge tapi daily check kan. Okay, dan compensated shock pula. Kalau compensated shock ni, okay, kalau compensated shock ni dia kita boleh nampak clear conscious, okay, shock can be missed if you do not touch the patient. Memang patient tu kita boleh nampak alert lagi, tapi bila kita pegang dia, kita dah boleh nampak CRT dia dah more than 2 seconds. Kita pegang dia, kita dah boleh rasa tangan dia sejuk, kita dah boleh, bila kita pegang dia, okay, kita dah boleh pegang rasa pulse dia, dah boleh rasa pulse dia weak. Lepas tu bila ambil BP, okay, bila ambil vitals, bila ambil vital sign, BP dah nampak, heart rate dah nampak tachycardic. Lepas tu tapi systolic pressure dia boleh jadi normal, tapi dia akan raise diastolic pressure, okay, and then dia akan narrow the pulse pressure, okay, so pulse pressure dia akan jadi rendah lah sebab diastolic pressure dia tadi dah raise, and then dia akan ada postural hypertension, and then kita boleh nampak dia dah mula ada tachypnea, okay, dan reduce urine output, dah mula kencing, dah kata kencing dah kurang kan, dan dia sangat dahaga, intense thirst. Okey, itu kita dah tahu dia sebenarnya dah dalam compensated shock, dia dah shock tapi masih decompensated lah. Okey, dalam decompensated ataupun hypotensive shock, kita dah boleh nampak patient is actually dah sangat dalam keadaan yang teruk lah. Okay, so patient pun kita dah tak alert macam biasa, kita dah nampak dia restless, kita nampak sangat lembik ke apa kan, And then kita boleh nampak CRT dia, of course bila kita pegang dia kita akan rasa tangan dia sangat sejuk, and then memang nampak pale, capillary dia, capillary refill time dia akan more than 2 seconds of course, and then pulse dia boleh jadi tak jumpa pun, and then bila kita ambil BP, severe tachycardia, and bila dah shock tu dah late in shock, dia boleh sampai dah sampai bradycardia. Boleh sampai satu tahap yang dah tak boleh nak record dah, unrecordable BP. Dah tak boleh nak ambil sebab dah terlalu hypotension kan, hypotensif dah. Dan dia punya pulse pressure dia, kalau boleh dapat pun pulse pressure dia adalah less than 20, and of course dia tak akan ada boleh jadi dah tak ada sangat-sangat sikit kencing ataupun tak ada air kencing langsung lah. So kita ada the 5-in-1 maneuver lah, the 5-in-1 maneuver magic touch, magic touch kan. So CCTVR, so apakah yang pertama? So dia kata hold the patient's hand to evaluate peripheral perfusion, so save life in 30 seconds by recognizing shock. 30 saat je untuk kita check whether patient tu ada shock ke tidak, probable shock ke tidak kan. So 5 CCTVR tu apa? C is color, kita tengok dia pink ke pale, and then kita pegang dia tu kan, kita dah boleh nampak tangan dia warm, color tu pink ke pale, and then capillary refill dia less than 2 second ke more than 2 seconds kan. So T is temperature, sejuk ke warm kan, and then V is volume, pulse volume, weak ke ataupun okay lagi kan. Kalau dah shock tu dah mula weak lah. And then 5 is rate, pulse rate. So pulse rate ni sama ada boleh volume pulse rate tu sama ada boleh masih kuat lagi ataupun tak boleh nak rasa dah ataupun weak lah. So investigation yang kita buat adalah in the early febrile phase, of course yang first kita patient datang ni mesti kita ambil FBC. So kita akan tengok dia punya white cell count, and kita akan tengok dia punya platelet, and then kita akan tengok dia punya hematocrit. So the decrease in white cell count is accompanied by platelet reduction. So hematocrit pula, a rising hematocrit is a marker of plasma leakage in dengue infection. The median values of normal hematocrit level among Malaysian populations are, kalau male less than 60 years old, dia 46%. Male more than 60 years old is 42%. Female in all age groups is 40%. So kalau nampak lebih daripada hematocrit ni raise, lebih daripada percentage ni, dia dah marker lah yang mengatakan ada plasma leakage ni. So be careful. So diagnostic test, biasanya kita akan proceed dengan, kalau kita nampak mana-mana salah satu dah drop white cell count ataupun platelet, kita akan proceed dengan dengue combo test kan. Itu adalah praktis kita yang dekat sini lah. Dia ada is dekat hospital sebab kita tak dekat sini. So daripada dengue combo test tu untuk confirm patient tu ada dengue combo test tu kita tu dah ada kan, NS1, IgM, IgG. So dekat situ kita tahulah patient ni sebenarnya ada dengue ke tidak lah. So triaging. So dekat triage ni is very important lah untuk tanya history of fever, sakit perut, vomiting, dizziness, bleeding, and urine output dia macam mana. So di sini pun kita boleh nampak kan mental state dia macam mana, bila kita ambil BP dia macam mana, bila kita pegang dia, kita check CCTVR ni, and respiratory rate dia macam mana. So management dia kan, overall first adalah history. First adalah history. Of course kita tanya fever dan ada illness yang tadi tu, sign-sign yang lain tadi tu, simptom yang lain, and then oral intake dia macam mana. Kita secara general kita akan tengok dia menjawab soalan dari segi mental state dia macam mana, and then urine output jangan lupa, and history of tadi tu lah, dia ada pergi travel ke, dia around duduk dekat lift dekat area yang memang ada dengue problem ke kan. Okay, so and then kita assess dia physical examination. Ini samalah sebenarnya assess hydration status, hemodynamic status CCTVR tadi, and then kita check kan abdominal tenderness, ada hepatomegalita, ada ascites tak. Okay, and then examine for bleeding manifestation lah kalau ada. Okay, and then apa yang kita buat adalah FBC, and then kita dan tengok hematocrit, and then kita buat combo test. Okay, so based on evaluation and history, physical examination and blood investigation tadi, point of care test, the clinician should be able to determine sama ada likelihood of dengue infection, and then the phase of dengue infection, sama ada dia berada di febrile phase, critical phase, recovery phase. So which one lah? And then the severity of the illness. Okay, so plan of management. So apa yang kita perlu buat adalah dengue assessment checklist must be filled. So kita kena isi lah yang kalau dekat ISO ataupun fever clinic tu ada yang dengue punya kan. So kita kena isi kat situ, and then notify the district health officer followed by disease notification form. So kita kena notify lah. So kalau practice kita adalah positif atau negatif dengue combo tu mesti kena notify. So if admission is indicated, stabilize the patient at primary care before transfer, and then communicate with the receiving hospital emergency department before transfer. So if admission is not indicated, daily follow up is necessary, especially from day 3 of illness onwards until the patient is febrile for at least 24 to 48 hours without antipyretics. Tanpa ubat pun dia dah tak ada demam. So itu kita boleh discharge lah. Okay. Okay, the decision okay. Patient can be discharged. Okay, sorry, sikit. Patient can be discharged if patient able to tolerate orally well. Okay, kalau dia boleh makan, kencing okay, and tak ada history of bleeding, tak ada warning sign. Dan bila kita buat physical examination dia semua stable lah, vital signs stable, kita pegang dia okay apa semua, insyaAllah dan hematocrit dia okay, stable hematocrit, and then no other criteria for admission lah, tak ada comorbid, pregnant ke ataupun children less than 12 months ke. Okay, so tu kita boleh discharge lah. Okay. Sorry, ada kat sini. Okay. So criteria for referral and admission lah. So first, bila ada warning sign, ada bleeding manifestation, inability, kalau dia tak boleh minum kan, keep on muntah, ataupun loya tak boleh minum langsung, reduce urine output ataupun ada seizure, dan itu adalah kriteria untuk referral dan admission lah. Signs, kalau dia ada dehydration, shock, bleeding or any organ failure, or any special situation, kalau patient with comorbid, ada DM, hypertension, IH, coagulopathy, morbid obesity, renal failure, chronic liver disease, COPD, or patient elderly, more than 65 years old, patients who are on antiplatelet and anticoagulant, kita tak nak further bleeding dia, or pregnancy, ataupun social factors, okay, yang menyebabkan yang patient tinggal jauh kan daripada KK ke apa, so kita nak admitkan dia, okay, untuk monitor lah. And then lab, kita nampak hematocrit dia increase, naik kan, with reduced platelet count. Okay, so fluid management in non-shock patients. Tengah record je, sekejap takut dah tiba-tiba tergelak aku. Sekejap So fluid management in non-shock patients, dengue fever with warning sign. In non-shock dengue patients, increased oral fluid intake may be sufficient in those who are hemodynamically stable and not vomiting. Inappropriate IV therapy had been shown to prolong hospitalization with a tendency to develop more fluid accumulation. However, IV fluid is indicated in patients with increasing hematocrit with evidence of ongoing plasma leakage despite increased oral intake. So, and IV fluid therapy should also be considered in patients who are vomiting, severe diarrhea and not tolerating orally. Okay, so kita ada maintenance of IV infusion lah. So in basal dengan non-obese patient dengan obese patient. So it depends lah. So adjust, kena ikut adjusted body weight and ideal body weight ni. Ada pengiraan dekat sini. So kalau non-obese patient 1 to 1.5 meals per kg per hour lah. Kalau obese patient dia kena ada calculated based on adjusted body weight. And graded fluid bolus regime obtain kat sini, obtain a baseline hematocrit before fluid therapy, give crystalloid solution, start with 5 mg per kg per hour for 1 to 2 hours, then reduce to 3 mils per kilo per hour for 2 to 4 hours, and then reduce to 2 mils per kilo per hour or less according to clinical response. If the clinical parameters are worsening and hematocrit is rising, increase the rate of infusion. Assess the clinical status, repeat the hematocrit and review if fluid infusion rates accordingly. So fluid in management ni equations with persistent warning sign. Okay, with increasing or persistently high hematocrit, kita guna yang graded fluid bolus tadi. Okay, must be initiated with cautious. And then frequent monitoring of clinical and laboratory parameters every 2 to 4 hours until patient improve. Aim for urine output 0.5 to 1 mils per kilo per hour. Reduce and consider discontinuation of IV fluid therapy when patients begin to show signs of recovery. So dalam dengue shock syndrome is a medical emergency. Okay, so recognition of shock is in its early stage, and fluid resuscitation will give good clinical outcomes. Failure to recognize the phase of compensated shock will lead to decompensated, which is hypotensive shock with more complicated disease, cause and organ failures. So pulse pressure less than 20 and systolic pressure less than 90 are late sign of shock in adults. Dah lewat sangat lah, dah lambat sangat, dah lama sangat dah shock tu. Okay, so fluid resuscitation must be initiated promptly and should not be delayed while waiting for admission to ICU or high dependency unit. Following initial resuscitation, there may be recurrent episodes of shock because capillary leakage can continue for 24 to 48 hours. IV fluid therapy is the mainstay of treatment for dengue shock. So this is the grade for dengue shock syndrome. So grade 1 kita boleh nampak daripada tourniquet ke, boleh nampak easy bruising. Grade 2 kalau ada easy bruising tadi and other hemorrhages, spontaneous bleeding. Okay, grade 3 adalah bila narrow pulse pressure ataupun hypotension with the presence of cold clammy skin. Okay, kita nampak circulatory dia tu dah tak bagus lah. So rapid with pulse and then grade 4 is undetectable blood pressure or pulse. So dah grade 4 lah. Alright, so this is the algorithm management in compensated shock. Okay, so kalau compensated shock, kita akan resusc with isotonic crystalloid 5 to 10 mils per kilo per hour. Okay, so kalau ada improve, ini sementara lah. Okay, by right, ini sementara sebelum kita transfer ke hospital lah. Okay, kita bagi dulu. Okay, kalau kita suspect shock, kita dah nampak patient tu in shock, kita start dulu fluid resusc with isotonic crystalloid 5 to 10 mils per kilo per hour for 1 hour. So by right sepatutnya kalau kita KK ni, kalau KKTI lah, kalau KK lain tu kena tengok kan, should be dalam 1 hour tu dah sampai dah hospital, but memang kita kena stabilize patient first lah. Okay, dia memang bermain dengan hematocrit kan. So kalau ada improvement then kita turunkan kepada 5 to 7 mils per kilo per hour for 1 to 2 hours, and then reduce lagi to 3 to 5 for 2 to 5 hours, and then reduce lagi to 3 mils per kilo per hour for 2 to 4 hours. Then if patient continues to improve, it can be further reduced lah. Then monitor hematocrit sama juga. Kalau improvement tu kita check hematocrit, tak ada. So kalau patient tak ada improvement, kita check hematocrit increase, kita bagi lagi bolus. Okay, tapi kalau hematocrit dah mula decrease, okay, hematocrit dah decrease tapi consider significant occurred overt bleed kan. So kita, apa yang kita buat adalah bukan bagi air lagi, tapi kita bagi pack cell kan. Dia tak improve kan, patient tu tak improve, tapi bila kita check hematocrit dah reduce. So apa yang kita buat adalah bukan bagi crystalloid ataupun bukan bagi lagi crystalloid ataupun colloid, tapi kita bagi pack cell, okay, blood components lah. Okay, this is algorithm B, fluid management in decompensated shock. Okay, so apa yang kita buat adalah fluid resusc with 20. Tadi 10. Okay, tadi 10, ini 20 lah, 20 ml per kilo. Collect crystalloid within 15 to 30 minutes. Tadi over 1 hour. Tapi in decompensated shock, kita bagi in 15 to 30 minutes. Lebih banyak collect atau crystalloid dan lebih cepat period of time nak kena habiskan tu lah. So dalam 15 to 30 minutes sahaja. Okay, so kalau improvement, ada improvement dan kita reduce. Okay, kalau ikut kat sini lah, kita reduce to 10 ml per kilo per hour for 1 hour, then continue with 5 to 7 in 1 to 2 hour, 3 to 5. So baca kat sini lah sebenarnya basically kan. So ni reduction lah sebenarnya. Okay, dan kalau tak improve, kita review hematocrit. Okay, review hematocrit. So sama juga, ni sebenarnya kebanyakannya yang kat sini dah sampai tahap dekat hospital lah. Okay, tapi review hematocrit sama juga. Kalau hematocrit increase, kita bagi lagi air untuk reducekan hematocrit kan. Tapi kalau patient tu kita check tak improve juga, tapi hematocrit dah reduce, mungkin kita dah tak boleh bagi air dah, kita kena bagi Paxel, mungkin ada bleeding lah. Okay. Okay, management of dengue in children. Okay, this is 2020 punya lah. Alright, okay, so dengue fever sama juga untuk anak-anak ni. If allow home care, advice for adequate fluid intake, sama je, warning symptoms semua sama. Okay, so kalau if allow home care, advice for adequate fluid intake, manage fever by tepid sponging and antipyretics, use dengue assessment checklist, follow up daily, provide and educate with home care leaflet. Kita biasanya kad dengue kita tu dah ada kat belakang tu sebenarnya, and educate the warning sign lah. So kita kena beritahu apakah warning sign yang dia kena cepat-cepat datang lah. Dan sebenarnya ada dekat belakang buku tu kan, ada dekat belakang kad dengue tu yang kita bagi patient waktu patient balik. Okay, ini adalah dengue assessment checklist for children yang sepatutnya kita gunalah. Okay, so kena tengok betul-betul CCTVR semua kita check. So special population kita tengok sini, age 12, less than 12 mesti kita refer dan admit, or any comorbidities lah, or ada any medical illness. Okay, so admission for criteria. Okay, so if kids tu age less than 12 months, dia ada presence of warning signs, a feature of severe dengue, or presence of comorbidities. Okay, admission may be considered based on social factors juga. If patient tu jauh ke, susah nak datang ke untuk hari-hari punya check up lah. Okay, so dengue fever with warning signs, admit for inpatient care, monitor hemodynamic status frequently, use hematocrit to guide interventions, use isotonic IV fluids judiciously, correct metabolic acidosis, electrolyte imbalance as needed. Okay, so fluid management dia, kita bagi isotonic crystalloid 5 to 7 ml per kilo per hour. Okay, ni kalau dengue with warning sign lah. If improve, reduce sama 3 to 5 for 2 to 4 hours, then reduce lagi to 3 ml per kilo per hour into 24 to 48 hours. Titrate IV fluids based on hemodynamic status, urine output, hematocrit kena monitor lah. And then stop IV fluid within 24 to 48 hours. Do not use hypotonic solutions, okay, such as D5 or half normal saline ke, ataupun 1/5 normal saline D5. Okay. Okay, dengue with compensated shock. Okay, kita bagi 10 to 20 ml per kilo in 1 hour, then reassess. If stable, gradually reduce the rate of infusion. If unstable, hematocrit increase. Okay, kita bagi lagi second IV fluid bolus. Kalau hematocrit decrease, kita suspect ada PR bleed ataupun apa-apa bleeding, then kita have to transfuse lah. Okay. Okay, and then severe dengue with hypotension. Okay, the management become very urgent. Stabilize the child. Run IV fluid normal saline 20 ml per kilo in 15 to 30 minutes. Then reassess. If stable, gradually reduce rate of infusion. If unstable, hematocrit, dan macam biasa sama juga tadi. Kalau increase, dan kita bagi collect. Kalau decrease, kita transfuse. Okay, so inter-facility transfer, all efforts must be taken to optimize the